are a group of anti-diabetic medication that is used to treat type 2 diabetes mellitus. What they mainly do is that they increase the insulin secretion as well as increase the insulin sensitivity and reduce the production of glucose by the liver. Their mechanism of action mainly relies in blocking the potassium channels in the pancreatic beta cells. This leads to depolarization of the cell. The depolarization results in opening of the calcium channels, which increases the influx of calcium into the cell. This influx increases the calcium concentration inside the cells, resulting in insulin release. So, sulfonylureas, there are many drugs under this group, but today I'm going to discuss glimepiride, glibenclamide, and gliclazide. The dose of glimepiride is 1 to 4 mg once daily, and the maximum dose is 8 mg. This is given usually with breakfast or with the first main meal. And the physicians, they will start as 1 to 2 mg initially and then increase it every 1 to 2 weeks depending on the patient's response. But the maximum dose is 8 mg. The glibenclamide, it's usually given as 1.25 mg and a maximum dose of 20 mg. It usually comes in combination with metformin at 2.5 mg and 5 mg. It's usually given once or in divided doses depending on the patient's response. Gliclazide can come in tablets or modified release tablets. The dose for the modified release tablets is 30 to 120 mg per day, given once or twice daily, also with the first meal or after breakfast. Usually it's given once, but depending also on the patient response, it can be given once or twice daily. It also comes in tablets. So the sulfonylureas, they interact with ACE inhibitors. The ACE inhibitors result in vasodilation. This vasodilation increases the insulin sensitivity. So when you give it with another substance that also increases the insulin sensitivity and increases the insulin secretion, it will result in hypoglycemia. Sulfonylureas also interact with non-selective beta blockers because the non-selective beta blockers will block the receptors on the beta 2 cells. And the non-selective and the sulfonylureas already work on the beta cells to increase the insulin secretion. Thus, when given in combination with beta blockers, this will decrease the efficacy of the sulfonylureas, resulting in hyperglycemia. They also interact with miconazole and fluconazole. Miconazole and fluconazole inhibit the receptor that inhibits the enzyme that breaks down sulfonylureas. Thus, it will result in an increase of their efficacy, leading to hypoglycemia. Sulfonylureas should not be given in diabetic ketoacidosis or type 1 diabetes.